I'm Anne Woolfield.
I'm Mel Akerman.
And I'm Carla Pecoraro, and we're your hosts of the Uterine Sound podcast, bringing you up-to-date information in all things ONG.
Today, we're covering a topic that sadly affects nearly 1 in 6 women, early pregnancy loss or miscarriage. Whilst pregnancy loss can occur at any gestation, early pregnancy loss refers to a non-viable intrauterine pregnancy within the first trimester, meaning up to 12 weeks and 6 days from the last menstrual period.
So I guess one of the first questions couples ask after being diagnosed with a miscarriage is, why did this happen? What did I do wrong? Women are so quick to blame themselves when something goes wrong in a pregnancy, and it's very common for a woman to reflect on everything she did to try and work out what happened. Was it that glass of wine I had? Is it because we had sex last night? Is it because my toddler bumped me in the belly? The answer to these questions is always no. It's so important to reassure the couple that there is nothing they've done to cause the miscarriage, and equally, there's nothing they could have done to prevent it. So why does miscarriage happen?
The most common cause of miscarriage is chromosomal abnormalities. Genetic abnormalities have been shown to be present in up to 70% of embryos between 6 to 10 weeks gestation, and 33% of fetuses between 10 to 20 weeks gestation. The abnormalities are typically aneuploidy, partial deletions, or duplications. Interestingly, the rate of chromosomal abnormalities under 6 weeks gestation is only 9%, which goes against what we were previously taught. It's hard to know exactly what causes these very early miscarriages.
Another cause of miscarriage is maternal anatomic abnormalities. Uterine fibroids, polyps, adhesions, and the presence of a uterine septum may be associated with pregnancy loss, depending on their size and position in relation to the developing pregnancy. These findings may not always be identified prior to experiencing pregnancy loss, but once they are diagnosed, they can often be surgically managed before another pregnancy is attempted. Now, not all fibroids contribute to pregnancy loss. Fibroids are very common, and in fact, most studies report no association between fibroids and pregnancy loss. It really depends on the impact of the fibroid on the uterine cavity and its blood supply.
A final known cause of miscarriage is abdominal trauma. Now, we're not talking about a little bump on the belly here, like you ran into the kitchen bench or your toddler used you as a trampoline. By trauma, we really mean the very obvious stuff, like a gunshot wound to the abdomen, penetrating injuries. Although trauma can also be iatrogenic, like chorionic villus sampling.
It's also important to note that miscarriage is incredibly common, affecting about 1 in 6 pregnancies. Because miscarriage is so common and women are very likely to go on and have a normal pregnancy the next time, we don't typically perform investigations for those structural abnormalities Mel mentioned until a woman has had recurrent miscarriages. Only about 5% of women have 2 miscarriages in a row, and less than 1% will have 3 in a row. The incidence of miscarriage varies throughout a woman's life and is largely affected by her age. Increasing maternal age is a significant risk factor for miscarriage, and this is mainly because of the increased prevalence of chromosomal abnormalities in pregnancies as a woman gets older. One study of over 421,000 pregnancies showed that the risk of miscarriage was lowest in women between the ages of 25 and 29, but even then, the chance of miscarriage was 10%. That rate rises to 17% after 35, 33% after 40, and 57% once the woman reaches 45. There's also a slight increase in miscarriage in women under the age of 20, sitting at about 17%, which is the same risk of miscarriage as for women over 35.
There's so much reproductive pressure on women to have children by a certain age, and I feel like this is just another thing for us to worry about. But I guess it is important for women to be aware of this when they are considering when or if they might like to have children. Now tell me this, we're always going on about women's age and the risk of miscarriage and the quality of the egg, but it takes 2 to tango, right? Where's the data on paternal age and risk of miscarriage?
While the impact of increasing paternal age is not entirely clear, pregnancy loss does appear to increase with increasing paternal age. Like with the egg, this is thought to be due to an increased chance of genetic abnormalities with aging sperm. Typically, the miscarriage risk increases with maternal age over 40.
And what are the other risk factors for miscarriage?
Well, there are some obvious risk factors like smoking, for example. Smoking increases the risk of miscarriage by about 30%. Now, this is strictly smoking tobacco. Marijuana smoking actually doesn't appear to increase the risk of miscarriage. Now, that's not to say that you should keep smoking marijuana, though. Weed has been shown to negatively impact on the developing baby. Other substances like alcohol and caffeine don't appear to increase the risk of miscarriage unless taken at large amounts. And for all you coffee lovers, we're talking more than 7 cups of coffee per day before the risk of miscarriage is increased.
Maternal medical conditions can also play an important role in the occurrence of miscarriage. Women with obesity, diabetes, or thyroid disease are more likely to go on to have a miscarriage than those without it. Maternal infections like syphilis and Zika virus are also associated with the high chance of miscarriage.
What about stress? We're all experiencing high levels of stress in our life since the COVID-19 pandemic. Can this increase the risk of miscarriage?
Stress is an interesting one. Acute and chronic stress can lead to increased cortisol levels, decreased immunity, and increased susceptibility to infection and other maternal conditions, which can then increase the risk of pregnancy loss. But if a person has an otherwise stable life, a short period of stress, such as a busy time at work or acute illness in a loved one, is unlikely to have a major impact. It's more things like significant periods of housing or food insecurity, risk of violence, ethnic and financial disparities, or other long-term life stresses. Interestingly, night shift is also associated with an increased risk of miscarriage.
Oh, don't get me started on night shift. Night shift is terrible for all aspects of your health. But doing ONG, we pretty much have condemned ourselves to a lifetime of night shift. So let's not depress ourselves too much by going into that. Other obvious risk factors include exposure to ionizing radiation or teratogenic medications. Also, if you happen to fall pregnant in the marina, you're more likely to miscarry if you leave the marina in than if you take the marina out.
Okay, so let's get into some of the terminologies of miscarriage. There are so many different types of miscarriage. Threatened miscarriage, incomplete miscarriage, complete miscarriage, missed miscarriage. What does it all mean?
A threatened miscarriage refers to bleeding with a perfectly healthy, viable intrauterine pregnancy. This is often diagnosed when a woman presents with vaginal bleeding and then has an ultrasound scan demonstrating a healthy embryo with a fetal heart rate. Threatened miscarriages are incredibly common, and it's a shame they have such a scary name. Most women with a threatened miscarriage will actually go on to have a normal pregnancy. It's important that women know that any pregnancy has a risk of miscarriage though, and so if her pain or bleeding increases, then she should re-present.
A missed miscarriage is also known as an asymptomatic pregnancy loss. This refers to a non-viable pregnancy in the absence of pain or bleeding. A missed miscarriage is diagnosed when the ultrasound findings meet the criteria for miscarriage, but the woman has yet to pass the pregnancy tissue.
An incomplete miscarriage is when some products of conception have passed, but some pregnancy tissue remains in the uterus. There's typically a history of pregnancy symptoms, followed by an episode of heavy bleeding with the passage of clots with or without recognised products of conception.
And a complete miscarriage is when the products of conception have passed and the uterus now appears empty on ultrasound. Now, it's important to point out that you can only be sure a patient has had a complete miscarriage if you have ultrasound confirmation of an intrauterine pregnancy with a yolk sac. If you don't have this, then the pregnancy should be treated as a pregnancy of unknown location, and serial beta-HCG follow-up is required until negative in order to exclude an ectopic pregnancy. Now, if you do happen to collect the products of conception, you can send them for histopathology, and that can be sufficient to confirm that it was an intrauterine pregnancy. But if not, you need that beta-HCG follow-up.
There are also a few terms that you may have heard of before that aren't commonly used anymore. Inevitable miscarriage was previously used to describe a miscarriage that cannot be avoided because the cervix is open, bleeding is heavy or increasing, and abdominal cramping is present. However, it can be difficult to differentiate between an open, external, and internal cervical os, and so this phrase is no longer used. A blighted ovum was previously used to describe the ultrasound findings of a gestational sac without a fetal pole. This is also known as an anembryonic pregnancy, or simply a non-viable pregnancy.
Now, probably the most important part of this episode, and definitely something we want our listeners to take away from this, is the diagnostic criteria for miscarriage. This is really important because sometimes women will be referred to the early pregnancy unit with a miscarriage and will be expecting to have a discussion about how to manage the miscarriage. But if you don't meet the diagnostic criteria, then we can't offer them treatment straight away. This can be really upsetting and frustrating for women, and so we really want to avoid this happening in the first place. So what do we need to be able to confidently diagnose a miscarriage?
We use criteria for the diagnosis of miscarriage with findings based exclusively on transvaginal ultrasound imaging. A miscarriage can be diagnosed on a single ultrasound if the crown rump length is 7 millimeters or greater with no fetal heart rate, or if there is a mean sac diameter of 25 millimeters or more with no fetal pole. Miscarriage can also be diagnosed if there is absence of an embryo with a heartbeat 2 weeks or more after a scan that showed a gestational sac without a yolk sac, or 11 days or more after a scan that showed a gestational sac with a yolk sac. You can also diagnose miscarriage if you have a previous ultrasound demonstrating a fetus with a heartbeat and a subsequent embryo demonstrating no fetal heart rate or intrauterine pregnancy. Now, this criteria is quite strict, but it's also very reliable. The criteria has a 100% specificity and positive predictive value, meaning if you meet this criteria, there is absolutely no chance of an ongoing viable intrauterine pregnancy. The point of the strict criteria is to make sure that there is no chance of incorrectly diagnosing a live pregnancy as non-viable, offering management for the misdiagnosed miscarriage, and then potentially terminating a healthy wanted pregnancy. The reason we have this criteria is because it accounts for variation in the quality of sonographer or radiologist, variations in ultrasound equipment, as well as the impact of patient factors like obesity, uterine fibroids, and uterine position.
Interestingly, the diagnostic criteria for miscarriage has changed over time. We previously used a cutoff of crown rump length of 5 millimeters with no fetal heart rate and mean sac diameter of greater than 16 millimeters. This was based off early studies in the 1990s that aimed to determine the embryonic size at which cardiac activity was always present in normal pregnancy. However, a subsequent study demonstrated a false diagnosis was made in 8% of cases based on a CRL of 5 millimeters and 4.4% cases using an MSD of 16 millimeters.
There are also some findings that are pretty suspicious for miscarriage, but not accurate enough to be used for diagnosis. These include a crown rump length less than 7 millimeters and no heartbeat, mean sac diameter of 16 to 24 and no embryo, absence of embryo with heartbeat 7 to 13 days after a scan showing a gestational sac without a yolk sac, absence of embryo with heartbeat 7 to 10 days after a scan that showed a gestational sac with a yolk sac, absence of embryo over 6 weeks after the last menstrual period, empty amnion with no visible embryo, and large yolk sac over 7 millimeters, or a small gestational sac in relation to the size of the embryo. So that's less than 5 millimeter difference between the mean sac diameter and the crown rump length.
Okay, what do we do once we have confirmed the diagnosis of miscarriage? What treatment options does a woman have available to her?
We typically divide the management options into expectant, medical, and surgical. Now, what's important here is that the woman is presented with all options and that your personal bias doesn't have an appearance in your counselling. The best evidence indicates that all management options are reasonable in the majority of cases, and patients are most satisfied when they are able to choose. Our job here is to present the different management options to the woman and allow her to decide. We'll start with expectant management.
Expectant management is essentially watchful waiting. Often the miscarriage will happen spontaneously with the onset of period-like cramping, vaginal bleeding, and the passage of tissue. Expectant management is often preferred by women who want to avoid medication and surgery for the treatment of their miscarriage and prefer to give nature a chance to take its course. It's also a reasonable choice for women who are wanting more time to consider their treatment options. The downsides of expectant management are that it can be unpredictable and it's not always effective. About 80% of incomplete miscarriages and 60% of missed miscarriages will resolve within 2 weeks with expectant management alone. The success rate drops with missed miscarriages and if there has already been prolonged loss without expulsion. Women do tend to experience more days of bleeding and a greater amount of bleeding than those who undergo surgical management. There's also a higher rate of unplanned hospital admission and unplanned surgical procedures in women who choose expectant management.
There is no limit on how long a woman should try expectant management before it is deemed to have failed. As long as there is no evidence of infection, expectant management can be continued. However, infection risk does increase with the duration of retained non-viable pregnancy tissue, and once it does set in, we recommend antibiotics and surgical management as emergency treatment. The NICE guidelines recommend conservative management for 7 to 14 days from the confirmed diagnosis, with the possibility to continue longer if the patient is well, with no signs of infection, and she is not compromised from bleeding. DIC can also occur with prolonged expectant management, although this is quite rare unless the pregnancy remains in the uterus for several weeks. At 4 weeks, the risk of DIC is about 10%. Women who choose expectant management can use NSAIDs or paracetamol to manage pain and should be advised to present to the hospital if they experience heavy bleeding or severe pain during the course of their miscarriage. By heavy bleeding, we typically mean if you're soaking more than 1 pad per hour for 2 consecutive hours.
Most hospitals offer follow-up at 1 to 2 weeks to confirm whether the miscarriage has occurred or not, and to assess whether the woman is happy to continue with expectant management or if she would prefer to try medical or surgical management. Some hospitals also use beta-HCG to predict whether expectant management is successful, with an expected beta-HCG drop of greater than 90% between day 1 and day 8. If this target has not been met, then patients will usually have another ultrasound to assess for retained products of conception. If there's convincing history of passage of the pregnancy tissue, then women are advised to perform a urinary pregnancy test at 3 to 6 weeks to ensure that it's negative.
So that sums up expectant management. Let's move on now to medical management. Medical management involves taking medication to speed up the process of miscarriage, either misoprostol alone or a combination of mifepristone and misoprostol. This option is usually preferred by women who would like some control over the timing of their miscarriage and the environment in which they do it, but would prefer to avoid surgery. Medical management may also be preferred to surgical management in women with uterine anomalies or cavity distortion who may be at an increased risk of complications from surgical management. Women are able to take the medication at home and can expect bleeding to occur within 24 to 48 hours of taking it.
The success rate of medical management is about 85% for missed miscarriage, making it a more effective option than expectant management. With incomplete miscarriage, there is no significant difference in effectiveness between medical and expectant management, although medical management may encourage the miscarriage to occur faster. The success rate is increased if we allow 2 weeks for the miscarriage to be complete, and also with the use of mifepristone. Medical management is definitely more effective for missed miscarriage than expectant management alone. The disadvantages of medical management include side effects from the medication, such as abdominal discomfort, nausea, diarrhea, vomiting and fever, a higher failure rate than surgical management, and a higher chance of needing emergency surgery due to either unacceptable bleeding or pain. Medical management has about a 2% risk of hemorrhage requiring blood transfusion and an 8 to 9% chance of retained products of conception requiring surgical evacuation. Follow-up is generally similar to that with expectant management. Beta-HCG day 1 and day 8 to confirm that the levels are falling. If the beta-HCG has not fallen more than 90% in 7 days, then an ultrasound should be arranged to check for retained products of conception. If there is a convincing history of passage of the pregnancy tissue, then women are advised to perform a urine pregnancy test at 3 to 6 weeks to ensure that it is negative.
Now, there are quite a few different regimes for medical management of miscarriage, and no one regime is perfect. Misoprostol-only regimes reported around Australia include misoprostol 400 to 800 micrograms as a single dose, given either vaginally, buccally, or sublingually, with a repeat dose given 24 hours later if the products of conception have not yet passed. Misoprostol can also be given as a 400 microgram single dose, with a second dose 3 hours later if the bleeding has not started. Mifepristone and misoprostol regimes include 200 milligrams of mifepristone, followed 24 hours later by 800 micrograms of misoprostol, given either PV, PO, or sublingual. You can give a second dose of 800 micrograms of miso 24 hours after the first dose if the pregnancy tissue has not yet been expelled.
So what is the deal with mifepristone and misoprostol versus misoprostol alone? Which one's better?
There are quite a few trials demonstrating superiority of the mifepristone-misoprostol combination over misoprostol alone. A 2018 randomized controlled trial showed that a combined mifepristone-misoprostol regimen was superior to misoprostol alone for the management of early pregnancy loss. Among 300 women undergoing medical management for miscarriage, those who received mifepristone had significantly higher rates of complete expulsion compared with women who received misoprostol alone at 83.8% versus 67%. The mifepristone-misoprostol regimen was also associated with a decreased risk of surgical aspiration to complete treatment at 8.8% versus 23.5%. Because of this combination is recommended by the World Health Organization, ACOG, Queensland Health, and the NICE guidelines. Although the NICE guidelines do differentiate between missed and incomplete miscarriage and do not recommend mifepristone in addition to misoprostol for the medical management of incomplete miscarriage. Mifepristone does appear to increase the success rate of medical management without a significant increase in side effects.
Mifepristone is an anti-progestin that binds competitively with the progestin receptor. This results in decidual necrosis whilst priming the uterus and cervix for prostaglandin activity. Misoprostol is a prostaglandin E1 analog that works as a uterotonic, making the uterus contract and expel the pregnancy tissue. When used alone, misoprostol has an overall efficacy of 71 to 76% up to 12 weeks gestation. Side effects are common and include nausea in 53%, vomiting in 20%, diarrhea in 24%, and pyrexia in 3%. Because of these side effects, it's a good idea to give the patient a script for ondansetron to take when these symptoms occur. Interestingly, there's also a study of 139 patients with miscarriage that reported highest rates of completion if the miso was taken 7 to 20 hours after mifepristone compared to if it was taken 21 to 48 hours later, 97% versus 88%.
Okay, finally, let's talk surgical management. Surgical management is by far the fastest and most effective way to manage a miscarriage. Women might choose this option if they wish to avoid the pain and bleeding associated with expectant or medical management, or if they want to resolve the miscarriage as soon as possible in order to return to their usual activities. Surgical management is also the most appropriate option for women who aren't suitable for expectant or medical management. For example, those with gestational trophoblastic disease, infection, excessive bleeding, or hemodynamic instability. Those with increased risk of hemorrhage or reduced ability to tolerate hemorrhage may also benefit from surgical management. For example, bleeding dyscrasias, inability to have blood transfusions, cardiopulmonary disease, and use of anticoagulants. The success rate is 99%, but there is a small chance of complications. These include perforation at a rate of 1 in 200, retained products of conception with need for a repeat D&C, cervical trauma in 3.3%, and intrauterine adhesions. Intrauterine adhesions, such as Asherman syndrome, can occur, although it is rare. This can result in the absence of menses and need for surgical resection of adhesions to improve fertility. It's also important to point out that women who choose medical management may end up with curettage and adhesions anyway, and those with retained products of conception may get infection, which is also associated with adhesions. Amniotic fluid embolism is a very, very rare complication, occurring in 1 in 10,000 to 1 in 80,000, although if it does occur, it has an 80% fatality rate.
Now, there are two main techniques used in Australia and New Zealand for surgical management of miscarriage: suction D&C or aspiration, or manual vacuum aspiration. Suction D&C is typically done in theatre under general anaesthetic, although it can also be done under sedation or regional anaesthetic. Cervical priming is often performed with 400 micrograms of misoprostol given 2 to 3 hours prior to the surgery to help soften and open the cervix and reduce the amount of mechanical dilation required. This can be administered vaginally, sublingually, or buccally, although side effects do tend to be less when the misoprostol is given vaginally. If the cervix is already dilated to 1 centimetre, a 10mm cannula can be used to empty the uterus quickly. If the cervix is not dilated, mechanical dilation is used. There is no set amount of dilatation used for each gestational age, but the general rule is to dilate the cervix to the same size in millimetres as the gestational age in weeks. For example, an 8-week pregnancy would require dilation to 8 millimetres. You would then select a cannula size that is equal to the gestational age of the pregnancy or 1 millimetre smaller. If the cervix is difficult to dilate, you can use a smaller cannula. It may take slightly longer to empty the uterus, but this is preferable to potentially causing cervical trauma. Most clinicians do a gentle radial sharp curettage at the end of the procedure to confirm the cavity is empty, although this step can be omitted. ACOG suggests that the routine use of sharp curettage, along with suction curettage in the first trimester, does not provide any additional benefit as long as the proceduralist is confident that the uterus is empty. The procedure is quick, simple, and patients are discharged home on the same day.
An alternative option to suction D&C is manual vacuum aspiration. MVA is performed with a hand-operated vacuum syringe under local anaesthesia. The procedure is recommended by the WHO for uterine evacuation and is used in many countries as an alternative to suction D&C under GA. MVA is a safe and effective procedure that is well tolerated by patients. Between 88 to 90% of women say they would have the same procedure or recommend it to a friend. MVA allows women to have the procedure done as an outpatient with no need to book theatre or undergo general anaesthetic. This results in a less intimidating and clinical atmosphere and allows the patient to have a support person with them at the time of the procedure. The woman does not need to be fasted before the procedure, and she can return to her normal activities afterwards. MVA is done under a paracervical block. The cervix is gently dilated and a size 6 to 8 cannula is inserted. The MVA device is loaded to create a vacuum and is attached to the cannula. Aspiration is typically silent and is completed with 3 to 5 passes of the cannula.
Now, when you first hear about the option of having an MVA in clinic, it does sound quite intimidating. Why would I want to have that procedure done awake when I can have a general anaesthetic? But actually, it is really well tolerated, creates a nicer environment for patients, and overall appears to be a much better experience for the woman. The Sunshine Coast University Hospital was actually the first hospital in Australia to offer MVA, and it's now routinely used for surgical management of miscarriage instead of a suction D&C. Several other hospitals in Queensland are also exploring incorporating MVA into their early pregnancy services. Having used it at SCOO, we highly recommend it.
Okay, now let's talk uterotonics. What do we do if we're performing a suction D&C and we're having bleeding at the end?
The first thing to do is to make sure the uterus is actually empty. Ensure you've removed all of the products. This can typically be done with the suction curette, by gentle radial curette, or by confirming the cavity is empty with the ultrasound. It's also important to consider the possibility of perforation. Next, we do bimanual compression. A little bit of fundal rubbing helps the uterus to contract. Oxytocin is commonly used. However, this is actually quite controversial. In theory, oxytocin receptor expression is dependent on pregnancy status and gestational age. The expression of oxytocin receptors and their binding affinity are thought to be quite low in the first trimester, and therefore use of oxytocin seems likely to be less effective. Despite this, oxytocin is commonly used around the world for surgical evacuation of first trimester pregnancy loss. The largest RCT of about 1,000 patients shows no difference in blood loss when oxytocin was used at the time of MVA, although other smaller studies have shown there to be a slight reduction in blood loss with its use. A recent 2022 study determined that timing of oxytocin administration may also be important, with oxytocin administration before curettage resulting in less peri-op blood loss than oxytocin administered after curettage. It doesn't seem like we have a definitive answer as to whether oxytocin is definitely beneficial or is definitely not beneficial, but there's certainly enough evidence to say that it probably shouldn't be used routinely. In the event of heavy bleeding at surgical management of first trimester miscarriage, other uterotonics like ergometrin and misoprostol can be considered. If uterotonics don't work, then most cases of severe bleeding can be stopped with a Foley's balloon. Place the Foley's into the uterus, inflate 30 to 50 mils, and tape it in place.
So that summarises the different management options available for miscarriage: expectant management, medical management, and surgical management. Women should be presented with all the information and then given time to make a decision. Remember, there is no right or wrong answer here, only the woman's preference. Women should also be advised that there is no difference between the 3 management options in terms of rates of infection, psychological outcomes, resumption of normal activities, subsequent fertility, and live birth rates 5 years post-miscarriage. So let's move on to post-miscarriage care. What about anti-D?
Although the risk of early immunisation is low, the consequences can be significant, and so administration of anti-D should be considered in cases of early pregnancy loss, especially those that are later in the first trimester. The first trimester dose is 250 international units in Australia. Anti-D should be administered within 72 hours of the pregnancy loss, but may be effective if given up to 10 days later.
Another important consideration is bereavement support. The loss of a pregnancy at any gestation is devastating for families, and although miscarriage is very common, it's important to remember that the grief reaction with very early pregnancy loss can be really strong. It's not only the loss of a pregnancy, it's the loss of the future the couple had envisioned for themselves and their family. Individual responses to a pregnancy loss vary widely, and many patients report psychological distress, depression, anxiety, and PTSD that can last for months. About 25 to 30% of people with pregnancy loss experience some adverse mental health outcomes, and so these women should be screened with the EPDS at follow-up. Linking families in with support resources is incredibly important to support them in their bereavement. SANS.org.au is a stillbirth and neonatal death support resource that supports couples with pregnancy loss at any gestation. Beyond Blue is also a useful website for people experiencing grief and mood changes following pregnancy loss. And the Glimmer podcast is another excellent resource, created by one of our lovely colleagues, Dr. Ashley Smith. The Glimmer podcast aims to support families through their bereavement.
So that brings us to the big question. What can we do to prevent miscarriage? Many different things have been studied specifically to answer this question. Unfortunately, this has just revealed a large number of things that are not helpful. Multivitamins, estrogen supplementation, uterine muscle relaxants, administration of HCG, complementary medicine, bed rest, and embryo selection have all not been shown to be helpful in reducing the rate of miscarriage.
The most common questions we get asked about is the role of aspirin and progesterone in preventing miscarriage. Progesterone supplementation does not appear to increase the live birth rate, including for women with recurrent pregnancy loss, and therefore it is not routinely recommended. Although there may be some benefit for women with recurrent pregnancy loss who are experiencing early pregnancy bleeding. We'll go into this a little bit more in a future episode. Aspirin is another medication we commonly get asked about. Unfortunately, there is not enough evidence to support the use of aspirin for prevention of recurrent miscarriage. In women with antiphospholipid syndrome, aspirin and low molecular weight heparin together reduce the risk of miscarriage. But this does not appear to be the case for women without antiphospholipid syndrome.
Another question we often get asked is, how long should I wait until I try for another pregnancy? So there's no evidence to say that delaying a subsequent pregnancy reduces the risk of a repeat pregnancy loss. Patients are often advised to avoid intercourse for 1 to 2 weeks to reduce the risk of infection, although this is not an evidence-based recommendation. There is actually some data to suggest that those who try to conceive within 3 months of miscarriage are more likely to achieve a live birth compared to those who wait more than 3 months. However, it's really important that couples consider their own emotional readiness when choosing the timing of their next conception. Ovulation can resume within days to weeks, and so if pregnancy is not desired, then contraception should be considered.
Hormonal contraception can be initiated immediately after completion of the miscarriage. There are no contraindications to the placement of an intrauterine contraceptive device immediately after surgical treatment of early pregnancy loss, as long as septic abortion is not suspected. The expulsion rate with immediate IUD insertion after suction curettage in the first trimester is not significantly different from the expulsion rate with placements at 6 weeks postoperatively, at a rate of about 2.5 to 5%.
So that brings us to the end of this week's episode on early pregnancy loss. Let's do a little summary to remind us of all the things we've covered.
First trimester miscarriage refers to pregnancy loss below 12 weeks and 6 days gestation. Miscarriage occurs in about 15% of pregnancies, and the incidence rises with maternal age. The most common cause of miscarriage is chromosomal abnormalities, occurring in 70% of miscarriages between 6 and 10 weeks gestation. Additional risk factors include maternal and paternal age, smoking, maternal medical conditions like obesity, thyroid disease, diabetes, and infections, exposure to ionizing radiation, teratogenic medications, stress and night shift, and the presence of an IUD.
Miscarriage can be diagnosed with 100% confidence on transvaginal ultrasound based on the following criteria: a crown rump length greater or equal to 7 millimeters with no fetal heart rate, a mean sac diameter of greater or equal to 25 millimeters with no fetal pole, absence of embryo with a heartbeat greater than 14 days after a scan that showed a gestational sac without a yolk sac, an absence of embryo with a heartbeat greater than 11 days after a scan that showed a gestational sac with a yolk sac, or if a scan that previously showed a pregnancy or heartbeat now doesn't show a pregnancy or fetal heartbeat. Management options include expectant management, medical management, and surgical management, and should be based upon the woman's choice.
Expectant management typically involves waiting 1 to 2 weeks to allow pregnancy tissue to pass spontaneously, and it is effective in 70 to 80% of cases. Medical management is most effective when mifepristone is used in combination with misoprostol. Surgical management involves either suction DNC under GA or manual vacuum aspiration under local anesthetic. There is no difference between the 3 management options in terms of rates of infection, impact on fertility, return to usual activities, psychological effect, or live birth rate at 5 years.
Post-miscarriage, anti-D should be administered for rhesus-negative women. Bereavement support information should be provided, including links to SANS, Beyond Blue, and the Glimmer podcast. Women can try for another pregnancy immediately if they want to, but if they don't, then contraception can be commenced immediately too. There are currently no known strategies to prevent miscarriage in subsequent pregnancies unless the woman has recurrent pregnancy loss and active bleeding, or antiphospholipid syndrome.
Thanks for listening to this week's episode of the Uterine Sound podcast. You can find our summary slides on Instagram later in the week. If you have any comments, feedback, or want to fact check us, please reach out on our email, theuterinesound@gmail.com. You can also reach us on Instagram and Facebook at The Uterine Sound and our website, www.theuterinesound.com.